My name is John Smith. I have the honor to serve on the board of 2020 Mom. I'm currently the vice chair for the board of directors, and it's my honor also to be able to present the next person to share their insight into this space. The person that we have today is Nkem Ndifu. She's a MSN, CNM, RN, is the founder and president of Loomis Transforms and creator of the Resilience Toolkit, a model that promotes embodied self-awareness and self-regulation in an ecologically sensitive framework and social justice context. Licensed as a registered nurse and nurse midwife, Nkem also has extensive postgraduate training in complementary health modalities and emotional therapies. She served on the Los Angeles County Trauma and Resilience Informed Systems Change Initiative Work Group and developed a pilot trauma-informed learning academy for peer support workers as part of Los Angeles County Department of Public Health's Trauma Prevention Initiative. Welcome.
So, let me see here. Even before we do anything, people are eating, maybe you wolfed it down, maybe you're slowly eating, but just to take a moment and, so much information has come at us, at our heads, at our hearts, at our bodies, to just stop and just see how we're doing with that. Right? Let's just stop for a moment. And so just turning inwards, and you can keep eating, don't have to stop any of what you're doing, but turning and observing inwards, just what's going on for you mentally, what's sort of the temperature emotionally, and how you're feeling physically. Just how much stress are you carrying? How relaxed do you feel? Just taking a mental note of that. And I'd actually invite you, if you have a neighbor, find your nearest neighbor and turn to them and introduce yourself, your name, if you haven't already, and one thing that you noticed when you did that quick little scan. Okay, and gently wrapping up those quick little shares. Again, this just helps us bring our whole beings into the space, right? Helps us connect. So I just want to review some objectives. So we know, I just think it's really important to be transparent about what we're doing. I know everyone blows through objectives, but I actually think it's very helpful so we're all on the same page. About we're going to start with self-care. Really, what is effective self-care? It's a question that's not asked very much. And talking about the relationship of our individual resilience to systems of adversity, right? Where do we sit individually in the ecology? And to just begin to start nudging forward your skill for self-awareness and embodied awareness of your own stress, maybe even trauma, and definitely relaxation responses. And how appropriate are your responses to any given situation that you find yourself in. And we're going to practice with a few little tools to help settle stress activation that's not adaptive and not serving you in the moment. Okay? So we can't do too much in an hour, but we'll try. All right? So I'd like to start with self-care. And if you could for a moment, and you can write this if you like, or just think about it, okay, is two activities. Think of two activities that you're currently doing for self-care. Two activities, again, mentally, or just take a note. And how often are you actually doing them? Like, truthfully, in the last 3 months, how are you doing those daily, or they're kind of your self-care things, but you haven't done them in 3 months, right? So this is just, being honest with yourself. And then probably the most important questions is, how well does the activity work for you? And how do you know that the activity is working for you as a self-care activity? How do you know? It's a question I often ask, and people look at me and say, that's not something I've really been asked before. Okay? So let's just spend a few moments in quiet reflection. What 2 things are you doing? How often do you use them? How well do they work? And how do you know they work? Okay. So I'm curious if a few folks would be interested in sharing out into the group what came up for them when they did this. I see one hand here and one hand here. If we could get microphones here and here.
On. Hello. Oh, okay. Hi, how are you? Okay, so self-care. My 2 that I thought about first, I went from 2 to 4, but my 2 that I thought about first was exercising and watching some shows after I put the kids to bed to unwind. Like, nobody bother me, I'm going to watch some, some shows on TV. So exercising works very well. It makes me feel better about myself mentally, gives me more energy. But how often do I do it? Not as often as I would like to. So this week I set a goal for myself to exercise 4 times. I've done it once, but I plan to do it again today, and then I have, a few more days left in the week. As much as I love my shows, they do keep me up later than I wish to, because you start and you're like, I'm just going to watch one. But then there's another episode that I didn't watch yet, and I need to catch up. And then it's like it's starting in 10, 9. I'm like, I'm just going to watch the first 5 minutes. And the next thing you know, it's like midnight. And I'm up all throughout the night with my adventurous night owl children.
So it sounds like you've got 2 things. One that helps you feel better about yourself, and one that sounds like it gives you some quiet down you time, but at the same time it robs sleep.
Yes.
Okay, so there's a trade-off there. Great. Can we hear from, we have Lasana?
Okay, self-care for me is nutrition. And I prefer to eat holistically, a lot of vegetables, salads, and things like that. And another thing is getting proper sleep. Then I feel like I can, I got everything. The base is good, with the nutrition and the rest, the base is good. And then other things I like to do is window shop, especially if I don't have the money. I like the window shop, and that motivates me to work. And then once I do get the money, then I can go get what I like. Then I can keep my environment nice, and that just makes me feel good about myself.
All right, so what I'm hearing here is feeling like my bases are covered, my foundation is covered, and I'm getting motivation and inspiration from my self-care, right?
Yes.
Right, let's do one more.
Hi, my name is Betsy Chavez. I work for Hannah Institute, and something that that I've learned recently, actually in the last 3 months, because I just started 3 months ago, is that we do pies, and that's it's a way of checking in and being in tune to what you're feeling intellectually, emotionally, and all that, as well as meditation. So some meditation, something I've never done neither one of those, and I've felt the benefits. Personally, I have 4 daughters, and one is 5 months, and so a nice warm shower is something that I can look forward to as part of my self-care plan. And so I try to do that as often as I can. I can't always necessarily do that, but as well as fit in 10 minutes of a workout.
Okay, so nice varied, and some in the workplace setting, some are at home, carving out some time and space for yourself. And so people are using all different kinds of things as self-care, and I want to dig in a little bit more about what is effective self-care. Maybe, oops, no, that will not do it. The qualities of effective self-care. Many times, self-care that works, it's more, I think many of us here are parents, and you know how your kids ask for sugar? They just want sugar, 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 and they want it. They just want it. But we would be negligent parents if we just gave them sugar, 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 everything they wanted. They want to stay up all late, late, late. We want to let them stay, right? If you give someone everything they want that feels good, it's not necessarily the care that they need, right? So effective self-care deeply feeds us, right? So those words like I feel better about myself, I feel motivated, I feel energized, I feel connected, I feel more whole, I feel re-inspired, I feel rested and rejuvenated. These are the types of words that are associated with effective self-care, right? It's after you do it, you feel better for it. Okay? And so there's this big confusion between self-care and self-indulgence. I'm known for like being kind of a truth teller and asking really hard questions even if we don't know answers. Those are exactly the questions we need to be asking. So I may say things that be like, ooh, that's a little harsh. But if we don't call things by their right name, we can't do the right things. Okay? There is nothing wrong with self-indulgence, but it is not self-care. If you come home after a hard day and you just eat the whole thing of ice cream because you like, I deserve it. And you do deserve it, right? You worked hard and you eat that whole thing of ice cream, that's self-indulgence. But how do you feel afterwards? Did that move you forward in care? No, it didn't. So don't call it self-care. It's self-indulgence, and that's okay. But be aware if this goes on. I mean, the same person can say, I had a hard day, I'm gonna shoot heroin. Like some things are okay and some things aren't. I had a hard day, I'm gonna Netflix binge. So what you do is either socially acceptable or not, but the impulse behind it is the same: to distract yourself, to get away, to numb out, okay? And again, I have no judgment, just call it what it is. And if that's your only thing you're doing and you wonder why it's not working, it's because it's like this. Maybe, I don't know if they have it here, maybe, no. If I'm watching a movie and it's really like scary and creepy and I'm like, ooh, and I just say, I can't take this, and I just press the pause button, I get a break. But when I press start, it's exactly where I left off. And that's what often self-indulgence does, is it gives us a break. And sometimes that's all you can get, and that's okay. But don't be surprised it's not moving you forward. It's not effective in the sense it's moving you forward. And so, and truthfully, if we look at the kind of hard work that many of us do, I love chocolate. There is not enough chocolate in the world to heal trauma. Okay, just, there isn't. You can only get so many pedicures. You can take so many baths. All right, I'm gonna try. Okay, so these are some things to think about. And now I'm gonna say some things that might be really hard to hear, but I'm gonna say them. We often hear in workplace settings that people should be using self-care to treat burnout. And I'm going to say really clearly that burnout is a result of systems problems. It's not having autonomy in your work. It is having unreasonable work demands and not being respected in your work. There is no self-care that is going to lower the paperwork that you have to fill out. There is no self-care that's going to house your clients or magically create affordable, accessible mental health services on every corner, right? So when we use self-care as a, and we see this a lot in organizations around burnout, that's a way to individualize a systems problem and for the system to not take responsibility for the creation of burnout. So I'm pushing back. Is self-care a good thing? Absolutely. It just is not a cure for burnout. Okay, now I'm going to take on vicarious trauma. Okay. First off, if somebody was assaulted and went for counseling services, would you say self-care? That's a good cure for your trauma. Would anybody say that? No. Why on earth would we ever think that self-care would be a cure for professional vicarious trauma? Self-care is not a cure for trauma. It is not a treatment for trauma. Is it an adjunct? Absolutely. But it is not a substitute for treatment. Are we saying that vicarious trauma is less serious than primary trauma? Is that what we're saying? So then if you're in your workplace and you're vicariously traumatized, self-care is enough because it's not as serious as primary trauma? And I'm going to push back on that. In some ways, I think vicarious trauma is worse because a big feature of trauma is feeling helpless. I can't do anything. Talk about being the provider of services and witnessing somebody having trauma or hearing a trauma story. There is zero you can do about. They are the ones of agency in the situation. So you are actually more helpless listening to someone's story. And in some ways, that trauma is worse. And I think it needs to be called out as such. And again, self-care is not trauma treatment. It's an adjunct. And so when we see workplaces, and I'm going to say self-care for their staff around vicarious trauma, they are abdicating their responsibility for providing their employees and volunteers with real substantive mental health care and pushing it onto the employee. So for folks who are working in management, this is hard to hear. For folks who are working as line staff, I think we know this is true, and it's hard to push back and say, you know, we need reasonable work conditions, and we need access to mental health care for us for how hard this work is. And we're happy to do self-care, but it is not a substitute. Thanks for the pizza party. Okay? So I know this is supposed to be about caring for the caregiver, and everyone thought, okay, we're all going to be doing like some breathing, and we're all going to do self-care, and we are going to do that. But I wanted to set the context that that is not enough, that it is not just the responsibility of the individual. It is the responsibility of the groups of people and organizations and communities that we work to take care of each other and create systems of care. Not just for the people we're entrusted to serve, but also for those of us that are providing services. So caring for the caregiver is a group affair. Y'all with me? All right, just checking. Or you're just zoning out on that chicken. Zoning out on that chicken. Okay, so no big surprise, self-care alone will not address burnout or vicarious trauma. So if you walk away from nothing else from this, please walk away with that. Right? And how do we create systems of care and for not, because we all know you can't give from an empty cup, right? And so when we really want to provide those services to the folks entrusted to our care, this is not just our responsibility to take care of ourselves, it's the systems that we work in to help take care of us too. Okay. That said, I'm not a fan of individualizing systems problems, but I also realize systems won't change themselves. Right? They just don't jump up and change themselves. Who's going to change them? You're looking at, we are the ones who are going to change systems. So how are we resourced in order to make those changes to the system that will better support us? How does that happen? Right? And here's where self-care is super important. That's where that self-resourcing allows us to have the bandwidth to make those changes. And so what I want to spend the rest of the time here talking about, most of the time, is about a system that I developed, a modality. It's a way of thinking about self-awareness and thinking about regulating our stress responses called the Resilience Toolkit. And I'm going to run you all through a mini toolkit. And it's really some of the, even that guiding question, that question that I asked at the beginning, how did you know your self-care works? That's one of our guiding questions, is like, how do things work? It's not just enough to say, here's a bunch of practices and use them. It's how to think about, when would I use one? How do I know it works for me? When do I stop using it? So it's a lot about thinking, not just the tools, it's the kit and how we think about it, okay? And so the Resilience Toolkit has some core components, 4 core components actually, about developing an embodied awareness of our own stress and relaxation. Because if you don't know where you are, you don't know if you need anything, right? Like if you didn't have a gauge on your car of how much gas was in the tank, how would you know you needed to refill it? You wouldn't know until you ran out. So it's really important for us to also have this gauge and understand where we are at any given moment. Okay? And it's not enough just us, we're not islands. How do we exist in our environments? How do we appraise, is our stress helping us or hurting us? Okay? Stress is there to help us perform, to help us defend and keep ourselves safe and those that we love safe. There's nothing wrong with it, right? It's just, is it matching? Is it helping me in this situation? I did a workshop yesterday for a homeless service agency, and and many of the people in the organization have lived experience, and so it's extra hard work, I think. And one woman, and so they really feel the urgency to do the work. And one woman was just like, stress is always bad. She could not imagine stress being good. And she had no, like really as we got into it, this idea that, oh, I could turn it off. Like there are times when it's helping me and there's times when it's hurting me. It was like just a novel way to think about it. So I just want to introduce that. And it brings in the importance of the social ecology around you. The third component of the toolkit is that we use brief mindfulness and movement tools that can be practiced in real time. This is not about going on a retreat. Retreats are lovely. Most of us don't have the time, time budget or financial budget to do so. And we often need relief in the moment. So what can be used in 15 seconds, 30 seconds, 1 minute, without anyone knowing that you're doing it in the moment when you need it, okay? But we provide guidance because different types of interventions work better or worse depending on your level of stress. Sometimes very high level, high stress load or a high trauma load turning inwards actually makes you worse. You may need rhythmic movement. So being able to have some guidance about where to start, what tools might be good starting points. But we use it's a very trauma-informed way of working in the sense of we're going to co-collaborate together to figure out what works for you and what doesn't. And in the process of figuring out what makes me more stressed, when I do that breathing, I feel more stressed, or when I do that, I feel more, how do you know? Right? So it develops your self-awareness and also a greater sense of self-agency, of control over what you want to do, given any response that you're having, which way you want to go. And we lastly use behavior change theory to support people of developing robust habits, to implement those changes into their lives, to work with ambivalence around how do I make these plans? How do I integrate these practices and perspectives to build? Because it's not like you can sprinkle fairy dust and you're resilient now. We know that that's a practice. Okay? So generally we like to work with people over multiple sessions, but we're doing a little mini toolkit today here. You interested? A little bit? Okay, we'll do a little one. Okay. So for this one, I'm going to use, it's a very common model that many of you, I'm sure, have seen and worked with, where social nervous system is sort of a relaxed state, a fight-flight is a moderate stress, and a freeze would be a strong stressor or trauma. This is one of many models that we use. Understanding that a model is not the thing, The Google map on your phone is not actually the roads in front of you. It's a map, it's a representation, and it distorts the road. This distorts, this misses things about chronicity. This misses things about gender. This misses things about social hierarchy. It's a very simplified model, but it's a useful model, and we're going to use it today, but recognizing that it doesn't encompass everybody's stress or trauma responses. Some people are like, that just doesn't fit me, because the model is not complete. Okay, but for this one, I usually like to start with the social nervous system, which is a relaxed state, and ask people to think about for yourself, how do you know when you're actually relaxed? When there's no threat and no demand, how do you know? Here, I was like, ooh. I heard some ooh in the room, right? Because if you can't answer that question, you can't evaluate, are any of your self-care methods working, right? So thinking back for yourself, does anybody want to yell out? How do they know? We can take a few. Yeah, just. Okay. So when she feels her thoughts slowing down. Thoughts slowing down. Mm-hmm. So breathing is just happening naturally. So what are they? Thoughts are calm. And so you're going to notice when folks say, I'm not this, I'm ignoring the not and I'm asking for the other side, right? Not, I heard you perfectly, I'm doing it intentionally. There was another hand?
When my self-care routine in the morning works, I experience more calm when I'm driving to work.
Okay. More calm when I'm driving. So what, here's another one.
When I fall asleep.
When you fall asleep. Okay. Mm-hmm. And some people can fall asleep, if anyone has ever had a fall asleep and then jerked, right? So an activity, by and large, doesn't necessarily mean that you feel any one way. You might feel a sense of settling, a sense of relaxation and letting go, while another person might feel terror in falling asleep. Okay? So in general, when we're in this state, we feel connected, we feel vibrant, right? We're curious, interested in new things, patient. We can access joy and love. Our bodies are relaxed, all systems working well. Our immune system, our hormone system, it's a symphony around that childbearing year, those hormones, but that symphony is in tune. And it's not just an emotional state, it's not just a mental state where we can focus and this type of thing. It's a physical, a biological state. It's all of those things. And so just to point out, there's like one thing I really like to drive home here is that when we're in that state, our nerves to our ears literally retune our hearing to the range of the human voice. We hear each other better here, biologically. The nerves to my vocal cords, you're going to hear a nice rhythm and tone shifts in my voice. And you don't really notice it except when it's absent. When somebody talks in a monotone, you know something's wrong. But that's literally the biology of the facial expressions. And this should be our baseline. Our culture doesn't support it so much. Our workplaces don't support it so much, right? This is a place where we heal and we rejuvenate, where we connect, where we dream, right? Where we grow. And so being able to know this place and return to this place is really, really important. Really, really important. And I like to center that when I start talking about stress rather than the high part. Like, let's talk about what this is. But we're also not supposed to be there all the time. That's also not practical, and it's not realistic or even healthy. You need a stress response, again, to perform or to defend. And so when our stress starts to rise and we go into maybe a low-grade fight-flight, how do you know? And I heard some of those, right? My brain is faster, right? I'm thinking about my breathing. What else happens? Tension. Who's the jaw clenchers? Who's the shoulders? Who's the stomach? Right? Even when you see, you wake up and you're kind of like constricted, right? What else? What else happens? Quick thoughts, rigid. I get very bossy. That's me. Irritated, short fuse. Work dreams, pressure dreams, chase dreams, hard to fall asleep, wake up during the night, wake up early, feel like you didn't even sleep.
Get too lenient, and then I regret it after, so it's more of a flight.
Flight, right? Like, whatever. I can't deal with that. Procrastination. Right? So there's a lot, we breathe faster, our temperature changes. In general, there's a sense of pressure, constriction, hurry. There's not enough time. Come on. Rigidity, focus, which is needed. Like when I worked doing deliveries as a midwife, somebody's bleeding. I need to be bossy and I need to be focused to make sure someone stops bleeding. That's appropriate, right? That's an appropriate response. So my vision just goes, whoom, right? Literally, right, to this. I need this, I need this, I need this, whatever we're doing, okay? So nothing wrong with this response. It's adaptive and life-giving when appropriately scaled to the situation. And I think we all know this very well. And even, Mary, I talked about the changes in the hearing. As danger starts to rise, our ears retune away from the range of the human voice to danger sounds in the environment, low sounds. And the best way to really, get this is imagine you were sitting around a campfire at night out in the wilderness, and suddenly you heard some rustling in the bushes. You would tighten, kind of hold your breath a little bit, like to see what it is, but your heart's beating, and you're trying to listen for what that is. So recognize that as stress rises, this is what happens to us as humans. We become impatient and short-fused, and we literally can't hear each other. Literally. And you know that if you've been in an argument with somebody, you're like, are you listening? Are you listening? Ain't nobody listening. And it's biological. So it's our responsibility in interactions, how do we get down into our social nervous system so we can hear one another? And so when you're working with clients and they're anxious and you feel like you're repeating yourself, and so you write it, they can't hear you. Doesn't matter how slow you talk, right? How do you help them settle? If you join them up there and talk faster and, then the two of you are there. How do you downregulate your stress response so they can join you? There's a sense of movement. I'm either moving towards, in confrontation, or to tackle a problem. It's not even a person. All right, to perform. There's a sense of movement or away. Hit the deck. Hit the deck. Okay, so this is our adrenaline, our sympathetic nervous system. So I'm going to, just right now, notice, how's your stress level feeling at this moment, talking about all this stress? Do you notice there's been a shift in your body, right, in your mind, in your thinking, from where I asked at the beginning? Maybe it's climbed up a little bit, okay? So I'm going to facilitate a couple of practices, and let's see if we can click it down a notch. In the toolkit, we ask, we're really doing these for stress reduction. So if they don't work for you, next, just skip. They're short. I'm going to facilitate. They're very short, 30 seconds, maybe a minute, and then the next one's coming. So if it doesn't work, just next. We do use some mindfulness tools, and I want to be very explicit that mindfulness in the United States particularly has been co-opted from Buddhism. Buddhism is a religion. And maybe you've heard me, if you've heard me speak, I've said this before and I say it often, is there is no religion whose goal is stress reduction. That is not the goal of religion. Okay? So the goal of Buddhism is not stress reduction. We have co-opted it for stress reduction. Buddhists recognize that when you do mindfulness, you turn inwards and you meet yourself. And that often is not a stress-free path. In fact, it's often a stress-inducing path, especially if you're carrying a lot of stress and trauma. When you go in and meet yourself, it actually typically makes things worse. And that is why it is an entire system where you have teachers, where you have sacred texts, where you have community that holds you through the path of self-discovery and self-liberation, spiritual liberation. Right? So when we co-opt mindfulness and we put it in an app, and you meet yourself, what happens then? Oops. And I can think, my organization was asked to provide services for a school-based program for pregnant and parenting teens that said, oh, we're going to be very trauma-informed and we're going to start yoga and mindfulness. And they did, and the girls stopped coming to school. Because you're asking them to meet themselves without providing any of that other stuff. Okay? So we are very intentionally, when we are providing these tools, that we are providing you with a framework to start understanding what does it feel like when my stress rises? What does it feel like when my stress settles? Providing support and guidance to choose which ones might support me, which might not. Providing ample encouragement to move away from discomfort and to orient yourself towards safety and comfort in this process, right? So it's not just, here's some mindfulness, which is often thrown around very cavalierly. It needs to be in a system of support. So as I invite you into the next practices, this is my way of saying, if it's not settling for you, next. That's not how we're using it, okay? And it's something to think about if somebody's saying, here, choose comfort, choose safety, choose ease, and you're like, no, I'm going to take the hard road. There are so many places in life where we're pushed beyond our limits over and over and over again, so much so that it actually erodes our resilience. The ability to rest, to know when it's safe to rest and rest effectively is actually super important for building resilience. So that's part of what we're doing here. There's no gun to anybody's head here. If it's uncomfortable, move away from it and see if you can practice that, okay? So, there's social nervous system, a little fight flight. I was into what I was saying. We're going to do some grounding and settling breath. So grounding is used in a lot of different ways and defined different ways. For here, I'm just going to invite you, again, eyes open or closed. This is totally optional. If you want to do it, is turning inwards to your mind. And just noticing, not so much the content of the thoughts, but is it cloudy? Is it clear? Stormy or still? Turning your attention to your emotional landscape. Is it loud or quiet? Not trying to make anything right or wrong, just noticing. Remember, if anything's making you more uncomfortable or more stressed, distract yourself. But if you're doing okay, drop a little further and noticing your body, feeling into the landscape of your body. What's comfortable? What's uncomfortable? And as you're observing yourself, as you're grounding, notice if your system is settling, your stress is settling, how do you know it's settling? What's telling you? What's shifting? What's changing? And now I'm going to invite you into a second practice. So if you took a break from the first one, welcome back. We're going to do a little breath, just noticing how you're breathing through your mouth, through your nose. Human body's very interesting. When we breathe out, our heartbeat slows. When we breathe in, our heartbeat quickens. So we're going to take advantage. The next time you exhale, just lengthen the exhale a little bit. Still an easy and relaxed breath, just a little longer than the inhale. Some people like to count, maybe 2 on the inhale and 4 on the exhale. Some people hate counting. Do what works for you. And if it doesn't work and you feel more stressed, return to a regular breath. If it is working for you, how do you know it's working? What's shifting? What's changing in your system? Is your mind slowing, clearing? Are muscles relaxing? What's changing? And now I'm going to invite you back into the space, if your eyes were closed, to open them, and if they are open, to focus them. So that was 2 practices, a grounding and a settling breath. You may have loved both. You may have hated both. You may have liked one better than the other. There is nothing wrong with the practices, and there's nothing wrong with you. Different strokes, different folks, different time. Bless you. I'd like to move us into talking a little bit about freeze. Freeze is, it's an overwhelm. It's when mobilization isn't adaptive, when shutting down, going numb, closing up works. There are multiple kinds of freeze. They tend to get lumped together. And obviously in this short time we are going to do a lot of lumping. There's the shock of something happening suddenly and you can't speak, you can't move, right? Actually called tonic immobility, and it's actually not compatible with life for very long. You can go into shock, right? It was first recognized in humans in sexual assault, but it occurs in many other places. We see, I think, often the slow grind of burnout where you don't care anymore, you're overwhelmed, you feel helpless and numb. That's a kind of freeze. Feel very stuck. The thing I want to emphasize here is that no one goes into freeze like, oh, I think I want to go and freeze today, that'll be fun, right? It's not like it's a choice. And we freeze for a reason, historical or current, meaning there was something where freeze was a better alternative. Freeze is a very metabolically costly survival mechanism. It is not chosen lightly by your organism. And so when it is chosen, know that the alternative is often harder, right? And so there's a great degree of numbness. Actually, you're producing your own opioids in this state. And so when you ask someone who has a lot of freeze on board to suddenly turn inwards, that's where things get really hairy and rough. So if any of you are using mindfulness and you're not really well trained, or your program wants to use mindfulness and some self-care, and the people who are doing it have had very little training, this is super important. Point to drive home, who are you working with and how are you holding this process? So the practices we use with mindfulness tend to, if we're going to turn inwards, we're turning positively, or positive orientation. Typically, we're looking at movement, rhythmic movement, or orienting outside of the body. Okay? And I kind of think of like a bubble of freeze. If we can pop it and settle. A bubble of freeze, can we pop it and settle? So I'm going to invite you into a couple of practices here. The first is resourcing. And so this, again, is turning inwards. I'm inviting you to scan your physical body, eyes open or closed, whatever feels safer and more comfortable to you. And you're scanning your physical body for what feels the best at this moment. What sensation feels the best? It might feel warm and lovely and yummy. It might just be neutral. And if you're carrying a lot of pain, it might just be less pain. But something is better than everything else. And see if you can locate that. What is the actual sensation? Again, if you're feeling more stressed, time to stop. But if you're doing okay, really noticing the location, the depth. How wide does it spread? And as you're observing this resource, this sensation in your body, is your stress level shifting or changing? If it's getting worse, you stop. And if it's feeling better, notice what's telling you it's feeling better. Again, muscle tension, breathing, what's shifting? And then I'm going to invite you into a fourth practice, and this is a movement practice that comes from EMDR, for those familiar with that. It was actually developed in Mexico after a hurricane for use with children in a low-resource mental health resource setting. And this, I'm going to demonstrate it first, and I ask you just to watch before trying it, because that's about choice. Like, you need to see what you're going to do to see if you even want to do it, let's say. So, and I want to show a few things too. So I've crossed my arms, and I will guide you through this if you do want to do it. And I'm setting my fingertips below my collarbone. And I'm tapping alternately. That's my butterfly, and I'm tapping alternately. And this is, if it's immediately uncomfortable, to please stop. If it's just meh, it's not really doing anything, you can vary the pressure or speed with which you're tapping, right? So I want to explain that to you, because some people put their hands on and then I'm still demonstrating it and they're trying to hold on, but it's really uncomfortable. I want to really open that up for choice before you even decide if you want to do it. So if you'd like to do it, you look at your hands, thumbs out, and you cross them. The thumbs can link or just rest together, whatever feels comfortable. And you're going to set that on your chest with the fingertips under the collarbone. And the hands are not sideways, but not constricted up, but orienting more towards your head, the fingertips orienting more towards your head. And from there, there's tapping. You can do it alternately, light, heavy, quickly, or slowly. It doesn't feel good, stop. You're enjoying it, enjoy. Again, you can experiment with pace, with depth. You like how it's feeling, what's changing for you? So we've done 4 things. Grounding, turning inwards, mentally, emotionally, physically, right? We did settling breath, the longer exhale than inhale. We did resourcing, find a most comfortable physical sensation, and butterfly hug, right? So just to think to yourself, which one did you like best? Which one did you like best? And how do you know? What did it do for you? And just kind of reflect on that for yourself. What changes you noted? Just reflecting on for yourself. And you, again, might not have liked any of them. So some signs that your stress is coming down. 1, you're moving from You're moving from a higher level of stress to a lower level, okay? But recognizing if you're moving from freeze, you don't just drop into your social nervous system, you have to pass through fight flight. So there can be that unnumbing where you actually go, you know what, I don't feel all that better. I actually feel more. And I've heard people say, it's like going from feeling dead to feeling alive. I feel more pain, but I'm alive. And that means you're moving towards settling. It's just, there's some ways to go. You may notice yawning. Yawning is a sign of nervous system downregulation. It's a social signal of safety. It has no bearing how tired you are. Over and over again, people think, I yawn because I'm tired. No, you feel tired because you're safe. Your body is allowing you to feel the tiredness. You've been pushing and pushing and pushing and pushing because for whatever reason it's not safe. And suddenly you feel safe enough, you yawn and you're like, wow, I'm so tired. And you connect the two. So I'm a big fan of uncovering our mouths when we yawn and changing that social norm. So I say it like all the time. Like I'm facilitating, I don't know, 6 times this week, 6 groups. I'm like, uncover, uncover, uncover. When I yawn and I look at you, that's literally from my body, which cannot lie. You can't really fake a yawn. It's saying to you, I'm safe. I feel safe here. Versus, what if I say, trust me? Right? Like every abuser says, trust me. It means nothing. But when I yawn, that's saying, trust me from deep inside. So when you work with people, if they yawn, fantastic. Uncover your mouth, unless you have food in there. Uncover your mouth. And we need more social signals of safety and okayness. That's why it's contagious, right? It's safe, it's safe, it's safe, it's safe, it's safe. I do want to point out that you cannot be in your social nervous system and a defense response at the same time. So some people will say, I'm so social. If you're slightly worried, slightly anxious, slightly irritable, you are in fight flight. It may be low fight flight. It may be very adaptive to your circumstances, but it is not your social nervous system. So just know that, right? And if you're finding no space in your day, in the places you work and the places you live that support the social nervous system, that's, you know, some cause for concern and what's being done about that. So if I can leave you with these guiding questions, these are from the Resilience Toolkit. These are your guiding questions. And so it's almost, even if you never use those 4 practices again, you practice the toolkit when you ask yourself these questions. What is my state, my stress state? And how do I know? Again, that grows your self-awareness when you can answer the question, how do I know? Right? Saying I'm anxious does not have a lot of detail. How do you know? Get granular. Is my response adaptive in the moment? Is it adaptive in the moment? If it's serving you, there's nothing to do. Use that stress to keep yourself safe, to perform, to do what you need to do. But when that situation is over, that's when you're realizing, is this no longer adaptive? It's not, if your stress level is not adaptive to the situation, what practice can I use? And you have many, many practices available to you beyond these 4. And the last question is, how do I know it worked? Because if it didn't work, next. I don't have a lot of time. Most of us don't. I want really effective methods to drop my stress level so I can stay attuned and responsive to the environment that I'm in. I don't want to be wasting energy where I don't need to be wasting energy. There's enough places asking for my energy where it really is needed. I don't want to be blowing it where it isn't. And when you repeatedly, 2 of the big determinants of resilience is self-awareness and the capacity for self-regulation. And this is that, right? And repeated practice helps you be responsive to the stressors that are actually showing up in your life. You're not stuck higher, right? If the situation is calling for this level of stress and you're always running this, that's a waste. What are you going to do with that extra energy? Okay? right? It creates allostatic load. It creates chronic health problems, chronic mental health, physical and mental health problems, right? And so can we build this level of resilience where we're actually tracking and responsive to our environment and not wasting that energy, right? So then we're able, something happens, we track with it, and then when the situation is better, we recover. We're able to bounce back, right? That's this level of resilience. But I want to offer even like a bigger North Star, so to say. It's not just about bouncing back from adversity, right? But what happens when we're not wasting that extra bandwidth? We can use it to change the very systems of adversity that are pressing on us in the first place. So when I talked about self-care in the context of we can't fix systems problems with self-care, but systems problems won't fix themselves, it's on us to fix them. We need to have this level of resilience to be able to fix systems problems. And we like to call this alchemical resilience, where you're able to transform those systems of resilience, right? Alchemy is making something greater from the original ingredients. Spinning gold from straw. I am at time, I imagine. So thank you all so much. I hope this was useful and supportive, and I'll be around for questions.
My name is Alin Barrera, and I'm one of the 2020 board members, and I have the honor to introduce our moderator for our next panel. Stephanie Telecki is CHCF's Director of Learning and Impact. She partners with the Foundation's program teams to support organizational learning, evaluate the Foundation's investments, and optimize impact. Stephanie also leads the Foundation's portfolio in maternity care as part of CHCF's focus on high-value care. Prior to joining CHCF, Stephanie held various positions in research and management, including serving as a policy analyst at the RAND Corporation, where she conducted health policy research and evaluations for such clients as the Agency for Healthcare Research and Quality, the Centers for Medicare and Medicaid Services, and much more, I'm sure. So please welcome Stephanie.
Hi there, and thanks for hanging in there. I know we have the kind of after lunch slump spot, and we've got a fairly wonky topic, so we're going to try to keep it interesting. I will say, and I know I'm biased, I think this is one of the most important topics, and I think it gets, as a funder who funds in this space of measurement, when people ask me what I'm funding and I start talking about this work and I get excited about it and eyes glaze over and people start looking at their phone, and this can be in the weeds topic, and I'm going to present today that it's fundamental to everything else that I think we're trying to do. So I hope you'll stay awake with us for the next hour. We do have a really all-star lineup here, and I want to introduce each of the speakers. This is going to be a little bit more traditional kind of panel setup today. Each of them are going to come up and present, and then we'll have a conversation afterwards and take as many questions as we can. So to my immediate left, we have Christine Rinke, who is an applied maternal and child health epidemiologist and the California MIHA Survey Project Manager, and she will tell you all about MIHA in a minute, with the Center for Health Equity at the University of California, San Francisco. And I'm going to keep these intros short so we have more time. Their bios are on the website. Next, we have Carol Sakala, who leads maternal health and maternity care programming at the National Partnership for Women and Families in Washington, D.C. She has importantly been the investigator on all of the national Listening to Mothers surveys and was the lead for the Listening to Mothers in California survey. And she also, importantly for this topic, co-chairs the National Quality Forum Committee that recommends performance measures for national endorsement. And lastly, we have Safine Byron, who is the Assistant Vice President for Performance Measurement at NCQA, the National Committee for Quality Assurance. She leads measurement activities in the areas of preventive services, Medicaid, and pediatric and maternal health care. So I'm very proud to say that all of these three fantastic women are grantees of the California Healthcare Foundation. And the work that they're going to talk about today is work that we have helped to fund along with a couple other co-funders, the Zoma Foundation that's been represented here, and the Yellow Chair Foundation, and also federal and other state dollars. So some people wonder sort of what's a nice funder like me doing in a place like this with a measurement topic. And so I wanted to spend a minute just telling you a little bit about who the California Healthcare Foundation is by way of introduction. So we're an independent nonprofit philanthropy based in Oakland. We give away about $30 million a year. Our maternity portfolio is about $2 million, and we focus on maternal mental health right now and birth equity for Black mothers. We've had other topics that we've focused on for various years before, but those are our topics of focus now. We focus on California and especially the Medicaid population, or Medi-Cal as we call it. We strongly believe in measurement as a really important underpinning to our work. So sort of why is that? Why are we investing heavily in this topic? Well, as many know, and people have thrown these statistics out, but the fact that so many women experience symptoms but are not officially diagnosed, and then if they are actually diagnosed, they don't receive treatment. So that's the sort of problem that we're trying to deal with, both from a prevention standpoint and from a healthcare system standpoint. And we know that it's concerning, and I know I'm preaching to the choir here, but we know that there's high prevalence of these conditions, especially in underserved communities and low-income communities. We know that the disorders are associated with negative outcomes for the mother, the family, the child. We know that they cost a lot. We just heard about that earlier today with the Mathematica study. And importantly, and really tragically, we know how to treat a lot of these conditions, and we're not doing it. And so that is the measurement world is about trying to understand what we're doing, how we're doing, and then try to figure out how do we fix it. So sort of how are we going to solve this problem? This is a quote from Peter Drucker, who's a sort of business management guru. Probably some of you have heard of him. And he famously said, and it's repeated over and over again, that if you can't measure it, you can't improve it. And that's really the point here. If we have no idea how we're doing at a societal level, at a state level, county level, et cetera, how in the world are we going to know what to do? And how are we going to know if what we're doing even matters or is sort of having any impact at all? So very simplistically, in the philanthropy world that I live in, we think a lot about what philanthropy can do, what any of us can do, and kind of what are the different levers for change. And so this is a very simplistic, you could add a lot more levers, but it's sort of what we're trying to do is in the middle, and our different levers that we can pull is circling around. And I would argue that the transparency, kind of monitoring data, information, metrics, whatever words you want to use to describe there, and I don't want to get hung up on the sort of words that we use, but the sort of information piece in the orange box really underpins every other lever. We can't attach payment to the desired outcomes if we have no idea how we're doing or what people are doing. We can't make good policies without good information. We can't engage consumers around the topic and let them know sort of how different providers are doing that may influence where they want to get care. And we can't improve quality without knowing where we're starting and seeing if we're getting there with what we're doing. So it really is the basis for so many things. And I kind of listed off some here. I'm not going to read through this slide, but these are all the ways, and I just kind of covered some of them in the prior slide, of how measurement, data, indicators, measures, whatever you want to call them, how the information can be used to help further maternal mental health in this case. And really, without reliable, valid measures that are importantly trusted by the people who are being measured, and that's a really important part of this, we can't make progress on any of the other things that we talked about, I think, during this conference, in my opinion. Now I'm going to do something crazy, which is like take the entire field of healthcare quality measurement and try to condense it into like 30 seconds. But just as background, and kind of in the orange at the bottom of this slide, there is the underpinning of sort of surveillance, public health, general sort of how are we doing writ large, big picture, 30,000-foot level. That underpins everything, and that's sort of the North Star, if you will, and both Christine and Carol will be talking to us some about the measurement work that they have done in that space. And then sort of in the delivery system, which is where CHCF funds and where kind of the rubber meets the road, if we haven't done a good job on prevention, is what are we doing in the healthcare system to address the different issues that are coming up. And for there's a famous model, Donabedian, structure, process, and outcome measures that we try to look at in the healthcare system. And by structure, we mean how care is organized, big picture things, how many hospitals in a healthcare system, how many behavioral health providers do you have, so really kind of counting type of measures and bigger picture. Those are kind of the least satisfying for a lot of what we do, but super important, and obviously the number of behavioral health care providers is critically important. So that's important to keep your eye on. Then there are process measures, which are sort of what is done. Did a woman get screened? Did a mother show up at her postpartum appointment? Those kind of things. And those can be extremely helpful in sort of directionally letting us know how we're going if we're tracking things that we know hopefully are associated with outcomes. And then lastly, outcomes, which are the holy grail, which is, rubber meets the road. How is the patient doing, and how did they experience the care? And those are sort of the key kind of categories of quality metrics when you're talking about in the healthcare system. Again, sort of very crudely, the talks that you're going to hear today kind of touch on some of these different things, and Carol and Christine are really coming at it from a higher level, 30,000 foot or a little bit lower, but not necessarily deep in the system in terms of what they're reporting on, and are doing that from patient self-report, from surveys. Whereas Safine, who will go last, is talking about sort of in the delivery system at the health plan level, how can we really track what things are going on. So I would just end my little opening remarks by saying I think the key points here just to take away from this, and really always looking for partners in this space, are it's really hard work. These are hundreds of thousands of dollars of efforts to collect data that are you're going to hear about today. It's hard work financially to get the funding to do this work and to continue it, and also to actually do the work, get the response rates, all of those kind of things. Nothing is perfect. You can criticize every measure that you're going to hear about and every indicator up here. We're doing the best we can with the funding that we have to get a window into how we're doing. Getting to individual level outcomes, which is really what we care most about. How are women, how are people experiencing care is very, very hard. It's very expensive, and we are still trying to figure out the data infrastructures to do it well. And that we need both. We need the surveillance, high-level measures, and we need the deep in the system measures. We need both of those things, and we need to keep our eyes on both of them to be able to sort of understand, again, where we are, how we're doing, and where we're going to hopefully go. So with that, I want to turn it over to Christine to come on up and take it away.
Good afternoon. Thank you all for showing up this afternoon and being here for this amazing two-day conference. I'm really honored to be here. It's the first time that I've attended, and it's really powerful to be in this space. So thank you very much for joining me in it. And so today I'm going to talk to you a little bit about the expansion of the measures that we have included in the maternal mental health measures that we've included in the MIHA survey, and to share with you some of the results of our prior work. So what is MIHA? It stands for the Maternal and Infant Health Assessment, which is California's annual postpartum survey. If you're not from California, you might be familiar with PRAMS, which is a postpartum survey implemented in many other states across the nation in partnership with the CDC. But like many things, California goes its own way, and we have MIHA. MIHA is led by the California Department of Public Health, the divisions of Maternal, Child, and Adolescent Health, and WIC, and is implemented by the University of California, San Francisco Center for Health Equity. And MIHA collects otherwise unavailable data that is used to guide program development and policy advancement. So each year, we sample women using a stratified random sample from live birth certificates of California resident women. We invite women to participate in the survey by mailing them a paper and pencil survey, old school style. And for those who do not complete those surveys, we invite them to complete the questionnaire over the phone in an interview or online through a web-based survey. We currently implement the survey in English and Spanish, but not in any other languages. The survey, as Stephanie mentioned, collects self-reported information from women. And we have a number of mental health measures, which I'll talk about today. But one of the things that we really focus on and really pride ourselves on is collecting information about the social and economic factors that really do drive many of the health outcomes that we see. And we're one of the unique sources to be able to make those connections and be able to draw some of those conclusions and establish an evidence base in that area. Annually, we have about 6,000 to 7,000 women who participate in the survey, and in recent years, our response rates have been just above 60%. We release data on a regular basis at the statewide, regional, and county levels. So next, I'd like to share with you the measures that we currently have on the MIHA survey related to maternal mental health. So that arrow looked different on my computer, but that's okay. So we ask women if they have a history of depression diagnosis prior to the current pregnancy that we're asking about. And we also assess whether women have depression or anxiety symptoms using a PHQ-based 4-question series that's been adapted for a retrospective postpartum survey. We ask this during pregnancy, and we also have a second series of questions that we ask postpartum. So using the PHQ-4, we have been able, with funding from the California Healthcare Foundation, to build upon our long-standing PHQ-2-based questions on depression to add a GAD-2, generalized anxiety disorder, 2-item ultra-brief screener, to get at anxiety symptoms, which we haven't been able to have at the population level in California. And then together, collectively, the PHQ-4 gives us a valid measure of psychological distress. So we do think that while these are very brief measures, they are going to be a great advancement to what we have been able to say about what is the percentage of women who are experiencing this statewide in California. Also, with funding from California Healthcare Foundation, we've recently added a question asking women whether they received screening for depression or anxiety symptoms during their pregnancy or postpartum. So we ask them whether it occurred during pregnancy and also whether it occurred postpartum. So we are, again, I'm glad you're feeling safe. Thank you. Whether we're able to, this is a process measure. It's a population-based process measure that will allow us to do apples-to-apples comparisons across women who are in any number or no healthcare delivery systems. So this is going to be something that I think is going to be very powerful. In 2018, we added a 3-question series on whether women felt they had a need for help related to emotional well-being or mental health concerns, whether they received counseling or treatment when they felt those needs, and what were their reasons for not getting emotional or mental health counseling or treatment in those circumstances. We have not yet released those data. We've just completed enough data collection to be able to dig into analysis. And again, support from the California Healthcare Foundation is going to allow us to do some really deep dive there and have a nice report on that. So we're looking forward to sharing that information, and maybe we'll be able to talk about it next year. So next, I'm going to share with you some of the results of some of our prior work. And as Stephanie said, this is really to give us that high-level evidence base for where we're at in California. Some of this, I think, will validate information that we already know, and will also perhaps provide a little bit of evidence to back up what we see in practice or in our lives and in our communities. So we'll just start out here. This is data coming from 2013 through 15 in MIHA, and 20% of women in California with a live birth are experiencing symptoms of depression either during pregnancy or in the postpartum. In California, that translates to 100,000 women a year. And MIHA also show that symptoms of depression vary by race, ethnicity, and by income. And these charts show the percentage of women with a recent live birth who experienced symptoms of depression. The red bars show the percentage of women who experience these symptoms during pregnancy, and blue bars show those symptoms postpartum. And while approximately 20% of Black and Latino women experience these symptoms during pregnancy, we see that compares to only about 10% of Asian or Pacific Islander women or white women. And then if we look at the chart on the right, we see that as income increases, the symptoms of depression decrease. And what we know also is that these women who are experiencing these higher prevalences are also the least likely to be able to be accessing services in response to them accessing the treatment they need to feel better. And as the numbers of hardships that women experience increase, so do depressive symptoms. And this is true about the hardships she may have experienced during her childhood, as well as pregnancy stressors. So I'll unpack this a little bit. So among women who reported none of the hardships that we measured during her own childhood, only about 10% of women in that group experienced symptoms of depression during and after pregnancy, compared to 25% of women who reported 4 or more of the childhood hardships, or ACEs, that we measured in our survey. The pattern is also true and more stark for pregnancy stressors. So among women with no stressors that we measured during pregnancy, for them, only about 8% experienced symptoms of depression. But among the women who reported 4 or more of the stressors that we measured, which includes really significant stressors, homelessness or housing instability, intimate partner violence, food insecurity, divorce or separation during her pregnancy, we see that 1 in 2 of those women who are experiencing 4 or more hardships are reporting symptoms of depression during or after pregnancy. And so while today and yesterday and in our daily work, we really focus on the very important activities of screening women, referring them to care, and getting them into treatment, what we can see is that in order to prevent these symptoms from arising, to prevent maternal depression, we really do need to start thinking about upstream through the life course and upstream in the social and economic systems in which women live. So those interventions that focus on healthy relationships, economic security, housing security, addressing racism in our communities and in our structures, those are the kinds of things that can really show marked change and bring down the prevalence of depression for women who are giving birth in California. And so I think there's a place for bringing this work together. And it's also really important to note that the slide I just showed the disparities we also see by race, ethnicity, and income. And while hardships occur to women in any walk of life, in any economic strata, we also know that Black and Latino women are experiencing these hardships at a much greater rate, and that women with lower incomes are also at more risk of experiencing these systems because they are part of the structure of our society. So finally, bringing us back a little bit closer to the conversation around screening and treatment, depression during pregnancy is a leading risk factor for postpartum depression. We know this from the literature. I just wanted to show a little bit of California data to kind of illustrate this point. What we see is that women who experienced prenatal depression symptoms, 50% of them went on to experience depression symptoms postpartum. But among women with no prenatal depression symptoms, only 7% went on to experience symptoms of depression in the postpartum period. So this is really evidence that shows us that screening needs to start early and needs to occur often during pregnancy. So finally, I'd like to acknowledge the funders of our work and the California Department of Public Health, particularly the Maternal, Child, and Adolescent Health Division, which has really been a leader in guiding this work with Title V federal block grant funding, and of course CHCF. And also, really importantly, the birthing individuals who participate in MIHA every year, many thousands of women who take the time to share their experiences with us and help us understand what's going on for women in our communities. So if you're interested in reaching out, here's some contact information. We'd love to hear from you. So now Carol's going to take a deeper dive.
So, good afternoon. I'm really excited to be able to contribute to this discussion with some of the things that we've learned from our Listening to Mothers surveys. And very briefly about the National Partnership for Women and Families, we work for a just and equitable society in which all women and families can live with dignity, respect, and security. And we do that through 3 different program areas that are very interrelated: access to quality, affordable health care, reproductive health and rights, and economic security. So today, I just have time to share some of the highlights of what we've learned from our surveys that we've carried out since 2002. And the final slide gives you information for learning more if you'd like to go further. And of course, you're welcome to contact me as well. So it's been a great privilege to give voice to those who care most about maternal health and maternity care mothers themselves. And the important thing to know about our methodology is that we work to provide population-based information. So if it's a national survey, we attempt to describe what's going on in the nation as a whole or for subgroups in the nation, and similarly at the state level as well. And we cover a very large range of topics from before pregnancy to well into the postpartum period. To date, we've carried out 1 state-level survey, Listening to Mothers in California, our most recent survey, and 3 national surveys. And for the 2nd and 3rd national survey, we were able to go back to the women who participated in the initial survey with a 2nd questionnaire. So we have very rich data sets, and we're able to pursue mental health over time as well. So you've heard about MIHA, and we did, both of us did a 2016 survey of women in California. And I'd like to just compare and contrast those surveys. In general, our focus tends to be more on the maternity care side of things, and MIHA tends to focus more on public health issues. But this is, of course, a topic that spans both of those. We are jealous that MIHA gets to go annually. We can only give surveys when we have money to do it. So they're kind of irregular, but happy to do them when we can. And lastly, we have not paper-based, but all of our surveys are computer programmed, and that allows us to drill down into topics, cover a broad range of surveys with a single survey. Broad range of topics with a single survey. I'd like to give credit to my co-investigators on all of our surveys, Jean DeClercq and Maureen Corey. And thanks also to the MIHA team at UCSF, which helped us do the state-level survey because there were so many issues that were relevant at the state level that they had already tackled admirably. The state agencies were fabulous, and lastly, thanks to our generous funders, California Healthcare Foundation and Yellow Chair Foundation. So all of our surveys have included validated mental health screeners, and it's really important to note that a positive screen is not a diagnosis. That would require the assessment of a qualified practitioner. The conditions we've been able to look at include prenatal and postpartum depression, prenatal and postpartum anxiety, and post-traumatic stress disorder after birth, as well as various other questions related to these topics. So turning to our results, the first National Listening to Mothers survey, women participated up to 24 months postpartum. So that was a really interesting opportunity to look at their rates of screening positive for postpartum depression over 6-month increments out from the birth. We used the Edinburgh Postnatal Depression Scale, and we found that 19% overall who screened positive had not consulted a professional with mental health for mental health concerns, but 43% who scored 13 or higher and screened positive had done so. And overall, 19% screened positive for postpartum depression. So here you can see the results in 6-month increments. Pretty high for the first 6 months, dropping for over the next year, but still quite high. And by 2 years, still very high. So this raises a question of whether we're talking about postpartum, perinatal, mental health issues, or something a little more related to women of reproductive age and those kinds of issues. And also I include one quote here just to say that we always collect open-ended comments from women that bring the data and the numbers to life. So our second Listening to Mothers survey, the first questionnaire, we included the PDSS, Postpartum Depression Screening Scale. This has a very inclusive cut point that is intended to pick up women who are experiencing minor and major depressive symptoms. And with that focus, we had 63% of all of our participants who screened positive. The reason we were really interested in using this is because it includes 7 subscales that look at different dimensions of postpartum depression. So if you look at the 2 columns on the right, you'll see the percentages of all of our participants who agreed or strongly agreed that in the past 2 weeks they were experiencing these various dimensions. So a very high rate said, I had shifting emotions, I experienced sleep disturbance, I felt some anxiety about my baby, all the way down to had suicidal thoughts, the lowest numbers, but still that's 1 in every 20 participant in the last 2 weeks before the survey. So the second survey, second questionnaire, we included a version of the PTSD screening scale, PSS, that a researcher named Susan Ayers had validated, adapted and validated for post-traumatic stress disorder after childbirth. So the questions are asked with reference to the maternity experience. And this was a real eye-opener for us because 18% of the participants in our survey appeared to be experiencing some PTSD symptoms after birth, and 9% appeared to meet all of the DSM-4 criteria. That tool tried to pick those up. So that's something that we think needs more attention. And here you can see that the distribution of screening positive for all the criteria was very uneven across the participants. So Black women were somewhat more frequent in screening positive than white and Hispanic women. Younger women were much more likely to screen positive for all PTSD criteria than older women. Women with Medicaid much higher than privately insured women. And if the woman had screened positive for depression in the first survey, she was much more likely to screen positive for PTSD. So moving to the Listening to Mothers in California survey, we were delighted to be able to offer this survey in English or Spanish, and we used the PHQ-4, which, as you heard, has 2 subscales of ultra brief questions to look at both depression and anxiety. And together, these are considered to be a marker for the severity of psychological distress. It was designed to look at the 2 weeks preceding the questions. We called on recall to ask as well earlier in the survey whether during your recent pregnancy you had experienced the various questions. And we had related questions as well in the survey. So 11% screened positive for pregnancy, for depression during pregnancy, and 7% screened positive for depression in the postpartum period. With respect to anxiety, 21% screened positive during pregnancy and 11% in the 2 weeks before completing the survey in the postpartum period. We also had high to low gradients that for both conditions by race and ethnicity and by type of payer. So prenatally, they went from most frequent with Black mothers, then Latina mothers, white mothers, Asian and Pacific Islander mothers, and with, again, with type of payer, Medi-Cal moms were higher than privately insured moms. Postpartum, there was less of a spread, but again, it was the Black moms who were most likely to have positive screens for both conditions. And that is something that we found over and over across many items in our survey. Alarmingly, just 1 woman in 5 with positive screens for either condition told us that during pregnancy, positive prenatal screens told us that during pregnancy she had received counseling or treatment for mental health, and just 1 in 3 with positive screens during the postpartum period told us that. So turning to some of the takeaways from our work, first, population-based surveys suggest the extent of maternal mental health conditions in the population, the extent of help receiving, and are important guides to policy practice, advocacy, research, many other types of responses. Postpartum depression, and I think we've seen that here in the comments from the podium, is most recognized and the biggest focus, most salient. But our results suggest that anxiety may be more frequent in both the prenatal period and the postpartum period, and also that both conditions may be more frequent during pregnancy than after birth. So we conclude from the prevalence of these conditions that screening and evaluation and access to treatment as needed for both conditions should be universal in pregnancy and after birth, and we urgently need nationally endorsed performance measures for perinatal anxiety and depression to foster this transition to widespread appropriate responses. Also, PTSD after birth warrants greater attention than it is getting. And lastly, regular population-based surveys to understand all kinds of things about the childbearing experience really are important. So here's my contact information. Please feel free to be in touch. And if you'd like to learn more, we have this slide for your guidance. And now I'll turn it over to Sophie.
All right, thank you, Carol. See if we can get this going. All right, well, thanks for being here to talk about data and measures. I'm a data nerd. I didn't realize how much that emanated until one day my daughter, who was then 4, emerged from the coat closet wearing my hat and my scarf, and my heels, and had my work bag slung over her shoulder. And she went, "Hi, I'm Safine. What are we going to do with all this data?" And I thought, wow, you picked up on that at the age of 4. It's really obvious. Okay, but I'm hoping I can make everyone else really excited about data as well. So I'm from NCQA. We develop measures. We are a national nonprofit based in DC, and our mission is to improve the quality of healthcare. And we actually are celebrating our 30th anniversary, and we really believe in measurement. It's full of data nerds like me. We believe that healthcare operates in the dark if you don't measure it. And if you measure it, you have transparency, and then you can push for accountability. You can tell people that this is what you're supposed to be doing, and you're not doing it, and we can show you the data that says you're not. So where do we fit in the quality landscape? Because there's a lot going on. You hear a lot about organizations, quality. I think in the very beginning, you have evidence development. That's where we have, the hardworking researchers, like those producing the mathematical report to say that this is, what we need to do to have good care. And then you have guideline developers like the U.S. Preventive Services Task Force and physician societies or clinician societies that say this is how we can bring about good care and put that evidence into practice. So here's where NCQA sits, and this is in the measured development round. We take that information, take those guidelines, and operationalize it into a measure. So we say that the guidelines say women should be getting screened for depression. And so we're going to develop a measure that says, among your women, did you screen them? And we'll talk more about that. Measures endorsement you may have heard about, the National Quality Forum. Carol is involved in this, others, and I think in this audience. These are folks who put a stamp of approval on measures and say, we have evaluated these with our process to say that they're valid and reliable, et cetera. And then you have measure implementers. And here again, you have NCQA. So not only do we develop measures, but we also use them in our accountability programs. And we think that's really important because it is important to measure, but it is also important to hold people accountable for the results. So I'm going to be telling you about 2 HEDIS measures that we developed. And what is HEDIS? It's the Healthcare Effectiveness Data and Information Set. It's a tool used by over 90% of America's health plans, and it's used to compare those health plans on important dimensions of care. And you can see that we've got over 190 million people who are in HEDIS reporting plans. Just some examples of HEDIS measures. They actually run a full range. They look at preventive care. So an example here, cervical cancer screening, right? That's recommended for women of certain ages. So we would go to a health plan and say, of your women who are 21 to 65, did they get cervical cancer screening according to guidelines? Did they get it every 3 years or every 5 years if it was HPV testing? We have measures that look at chronic care. So among your members who have diabetes, is their blood sugar controlled? Behavioral health, we have measures that look at, we'll talk about depression, but here's another example, which is metabolic monitoring. If you have kids who are on antipsychotic medications, which are very powerful, are you monitoring their metabolic readings? And care coordination. So if you've been hospitalized, did you have a proper handoff that included communication that went back to your PCP? These are just examples of some of the measures that we have in HEDIS. And we think this is important because HEDIS measures are widely used. So as I mentioned, it is used by NCQA. We do health plan accreditation. So we accredit health plans based on whether or not they have the right structures in place to take care of their members and on how they do on their HEDIS measures. So it is performance-based accreditation. We also have a tool called Quality Compass, and here's where we publicly report the results of health plans and how they do on measures, by health plan, by name. You can look them up and say, oh, so only 50% of their women are getting their cervical cancer screening. And the model here is that a health plan knows who their population is, right? Because you have to enroll. And so they know their enrollees. And while people might be going to a lot of different providers, and providers may suddenly get someone who shows up on their doorstep, a health plan knows that this person is in my plan, and I can monitor to see if they got the care that they should be getting according to the evidence. And so we published that on Quality Compass. We benchmarked to say that here's the average, here's what the good performing plans are getting, here's what the low performing plans are getting. So it's really important. HEDIS is used in programs here in California. So the Align, Measure, Perform program uses HEDIS measures. This looks at provider organizations. It's run by the Integrated Healthcare Association. It's used to compare states in Medicaid. So this is the Medicaid core set. They have a core set for children, for adults, and for behavioral health. And it's also used by CMS in the Star Ratings program for Medicare Advantage. I mean, millions of dollars are at stake for how plans are doing on these measures. It's also used in the quality reporting system for plans who participate in the marketplaces and many other programs. So all that is to say that, we think it's really important to get measures for maternal health in HEDIS. So where are we today? So you're going to hang with me because I'm going to tell you a little bit about some data. But if you think about maternal care in terms of access to care and effectiveness to care and the prenatal and the postpartum period, HEDIS measures draw primarily from claims data. So a health plan, that's the information they have for them, right? If somebody billed for a screening, then they can see that it happened. So they're using that information to understand whether their enrollees are getting what they should be getting. For information they can't get from claims, they usually have to draw a sample of medical records and search through that manually to see if something happened. It provides information that you can't get from claims, but it is resource intensive. But that's where HEDIS has been for a long time. And based on that, the measures that we have had for prenatal and postpartum care tended to be around, did they get a visit? Right? Timely prenatal visit. Did you get a visit in your prenatal period? Did you get a visit after delivery, within a certain amount of time? And that is really important, but it does not go far enough. And I'll say this, it's a HEDIS measure, so I can criticize it, although I'm sure my organizations wish I would stop. But, we got to go beyond visit count measures. So we have recently started pulling in more data into HEDIS in a more standardized way, and that is electronic clinical data. And it really opens up better measures for us. So we just added a measure called prenatal immunization status, and this says, among your women who are pregnant, did they get, a flu shot and a Tdap shot? Because that's really critical. And it uses gestational age as a way to specify where the woman is along in her pregnancy, because that is critical information, right? I mean, that's something that you should track your whole pregnancy, and it really has not been required in measures that we've had, at least in HEDIS. And with that, we're able to look at better measures for maternal care, and I will tell you about these two measures in a second. But our goal is to get to relevant women-centric measures that work within the context of the U.S., which we'll talk about as well. So the prenatal depression screening and the postpartum depression screening and follow-up measures were funded by the California Healthcare Foundation and the Zoma Foundation. I just really want to thank Stephanie and Rebecca for their vision here, and really believing in us and allowing us to explore these measures, which are hard, and we'll talk a little bit more about that. They apply to commercial and Medicaid plans. They draw from electronic clinical data sources. So that means that in addition to the claims that health plans have, we are encouraging them to go out and get that information from electronic health records, case management systems, and other data that are found in a structured field, because our belief is that you should be able to pull that information without having to go and manually dig through papers. And being able to get the information in that way means that measurement hopefully is a little bit more efficient, and it can be shared back and forth. So the plan should be sharing that information back with the care teams on the ground, because as providers, you need a full picture of the patient when you are providing care. The other thing I'll point out is that it requires use of a standardized tool, because we know that a validated screening tool is important for both, making sure we detect the depression and then also monitoring. It also requires proper follow-up. So we don't want to just screen and then allow the woman to fall through the cracks. We want to see that follow-up occurred. That could be medication, it could be a behavioral health encounter. There's a whole bunch of things. So I'll just touch on these, because I think we're probably going to talk about these in our talk, and I think I'm also running out of time. But, when we develop the measures, there are a lot of things that come to light in terms of maternal care in the U.S., right? Knowledge, we have to get more information on what's the optimal timing, what are the thresholds we should be looking at in terms of screening. Policy and payment. So the fact that a lot of women lost coverage or lose coverage currently in many states at 60 days is a big problem, because the recommendations say you should screen at 12 weeks or even a full year afterwards. And it's hard for us to hold a health plan accountable when they lose their member. The health system, we want to make sure that they are connecting the information, they are touching women where they meet the system. So we all know that many times after birth, the times that you're going to see a mother is at the well baby visit, right? And so that's where we should be screening as well. And data. We need to link information between the mom and the baby so that the health plan can see where that stuff is happening and be able to track it. So thank you very much, and I look forward to our discussion.
So the biggest thing that when I have attended panels like this and kind of heard the audience chatter is sort of so what? So like from where I'm sitting in my universe, and I know a lot of you don't live in the measurement sphere, sort of, what, so we have these measures, or what am I supposed to do from where I am? So I wanted to kind of pose to each of the panelists sort of, given the work that you've done, what is sort of your dream for what happens, especially kind of advice to this audience, which is not, health plan management and those kind of folks, or, maybe even not even people in the state, sort of what would be your ideal for how these metrics can be used, and also what kind of promotion or whatever that you would like to see happen from the types of groups and attendees that are here today. So Christine, I don't know if you want to start.
I think just very briefly, since we have so little time, I would say that to encourage folks to think about the population level, to think about who's being left out, who are we missing, where are those equity issues, and how can we all look for opportunity to step forward and help to make that transformation in the system to make sure that we are filling in those gaps. So I think that it can really show us about the population that is not coming through our doors if we're thinking kind of at the clinical or interventional level.
So as advocates, I would encourage you to push to go beyond postpartum depression, to look prenatally consistently, to look at the postpartum period, to look at anxiety, to look at depression, and to look at PTSD. I think all of those issues look to be quite prevalent from the work that we've done in this population at great cost to probably our society, but certainly our mothers and families.
So I would say that, as providers, making sure that you are capturing the information so that we can be monitoring what's happening is really important. Working across systems, knowing that mothers go to a lot of different settings for care. And so thinking about how we can link together providers so that they are working together to care for moms and not in the silos that is really just, it happens in our fragmented system, unfortunately, and it's an uphill battle. And I would say as advocates, pushing for, I was excited to see the work to extend Medicaid, covering women longer than 60 days postpartum. That is critical. And also just having the awareness around depression screening and follow-up, knowing that we're measuring out there and we really want to see it happening. And I would imagine it's probably happening a lot more than what we're seeing in the data. So.
Thank you. So an important thing that we know is that Medi-Cal pays for half the births in most states. It certainly does in California, nearing a half. So my question, and it may be primarily to Christine and Carol, but Zafine chime in too, is sort of what do we know, especially from your data about the Medi-Cal population, such that you can comment on it, and how in particular can advocates and those in the audience sort of focus in on that really important and more vulnerable population?
Medi-Cal has decided that screening is a part of the global fee. They're not going to pay extra for it. So that means people do not have the incentive to even start by screening. So that's one thing that Medi-Cal could do, is take that out of there. And I'd also like to give a little advanced preview of a paper that we have developed, secondary analysis from listening to mothers in California. It's adjusted, comparing the experiences of women with Medi-Cal and with private insurance. And the women with Medi-Cal, even adjusting for as many factors as we could, and it was interesting, the variables that we had in our survey to do so, they're struggling with access to autonomy, respectful treatment, et cetera. So these are issues that I think Medi-Cal is going to need to really try to deal with.
I might just say briefly that I think that particularly as there's been a transformation in the system of care, to remember about the comprehensive perinatal services program available to women during the prenatal and postpartum period, and to really think about making sure that women who are entitled to those benefits are getting them, even though they might not be in a Medi-Cal plan before pregnancy. They might be on the exchange in another plan, and really not losing those benefits.
I'd love any thoughts on, we're obviously aware of a lot of inequities, especially for Black mothers and birthing people, and I'm curious if any of you have any insights. I know, Carol, from the work that we funded, we did a whole issue brief specifically on that subpopulation, which was oversampled in the California survey, but any thoughts on how using measurement can hopefully help us on the equity front where we need to make a lot of progress?
So getting back to the comment that you made about if you don't measure it, you don't know, we strongly feel that the measures where it's appropriate should be stratified so that you're looking at how you're doing for the different population groups, and then you can turn to issues of accountability and special programs such as you've funded in California. So that's one part of the picture.
Yeah, I would agree with that. I think that if we, and again, it comes down to data because most people are not collecting information. You know, we need to have race, ethnicity information. We need to go further now and look at social risk information. And we just don't have that information in a standardized way. So the more we can get it, the more we can actually take these measures and look at it by these different groups to show that even if you're seeing an average of 50%, you might see a way lower rate if you are looking by, at-risk groups, and it is so critical to be able to shine a light on that.
And I think that we're really learning from the Black-led organizations who are doing work on the ground about the importance of really looking at both implicit bias and racism that's happening within the systems in which we're working, as well as the structural factors that are producing these inequities that we're seeing on the ground. And I really truly think that the only way forward is if we are inviting the women who are affected to the table to participate in these quality activities, to participate in discussions about what we are measuring, to participate in discussions about what, say, the MIHA data are saying is what's happening in the community, and how are these systems that we're working in able to partner with these women to think about how we can transform the systems that we're all operating in to better serve them. And so I think that we need to do it together in partnership and really think about changing the way that we work at every level.
I think we're out of time, so I'm sorry that we didn't get to questions, but all of us are available. I want to leave you with one thought that was really came out of the Listening to Mothers work that we did in California, and to me it's very poignant. It's what that data, and I think a lot of the other data that has been talked about up here also shows, is that women really know what they want in their maternity care in general, and what they want is actually consistent with what we know is the best care. That's both on the physical health side and the mental health side. And so, many times in healthcare, what we want in the United States doesn't make sense. Like we want, a CT scan for every little thing, and we want the high-end drug that buys you, one extra day of life for $300,000. And, there's a lot of things that we do that are a little bit, just don't make a lot of sense in terms of our demand. But this is one kind of miraculous place in healthcare where what the patient wants is actually consistent with what we know works. Midwives, doulas, people caring about each other, and our healthcare system continually does not do it. And it also saves money, by the way. So it's like just an insanity of what we do over and over again in this country. These data, certainly the Listening to Mothers survey and the MIHA survey, have a lot of very poignant quotes and things like that that I encourage you as advocates, that those are things that you can use when you are in your spaces and in your worlds to really lend voice to the issues. And there are a wealth of resources. MIHA and Listening to Mothers has a lot of issue briefs and reports and things, so I encourage you to go to some of the web links. And I hope with all of our help that the HEDIS measures will be widely implemented so that in a few years, Safine can get up here and tell us how health plans are doing. Thank you all for hanging in there.